Okay, so good morning, everyone, and I'd like to thank the organizing committee for the invitation to speak today about newborn sequencing and public health considerations from a U.S. perspective. So as a disclaimer, I will not be taking a position on behalf of the federal government or state U.S. state newborn screening programs, and I will not be making interesting policy statements or advocating for any position in particular. I will, however, be stating just what we know about the U.S. Newborn screening programs and the challenges in the context of a discussion on newborn sequencing. So in my talk today, I will give a brief background on newborn screening in the US. I'll touch on the current role of molecular testing within newborn screening programs. Then I'll discuss the experiences from the application of molecular testing and end with a discussion of considerations for integrating public health newborn screening programs with newborn sequencing projects. So let's get into the background. As you already know, newborn screening is not a test, it's a public health process. And that's successful. It's successful when the entirety of the system is being considered, so pre-analytical considerations, analytical, post-analytical components, and so on. All of these things need to have undercutting with important considerations around education, communications, ethics, and equity. So this schematic illustrates that newborn screening, even with the use of molecular testing, is still only risk assessment. On the left, in a seemingly healthy population of newborns, filter paper evaluation of biochemical and molecular targets allow us to separate out those that are high or low risk from having a disease, a specific screen disease. So high-risk newborns go on to have orthogonal diagnostic testing to determine if the screening results were a true or false positive for the target disease. With screening, of course, we can't forget those that are deemed to be low risk. So while the vast majority of these are actually truly unaffected, there does exist some real possibility that an affected child is actually missed by the screen. This slide highlights four important hallmarks of newborn screening within the U.S. The first is that newborn screening programs are public health programs and are administered by the states. They rely on a coordinated effort of numerous partners across a variety of different sectors. And while federal recommendations do exist on which diseases are deemed appropriate for population-level testing, it is still up to the state to determine how to operate their screening program, which diseases to screen for, and even certainly which test platforms are used. So this leads to a lot of variation across all newborn screening programs in the U.S. The next point is particularly salient when we're talking about the expansion of newborn screening to include sequencing, and this is that newborn screening programs in the U.S. operate under sort of quasi-mandates, whereby specific consent is not obtained from the family. The default is for newborn screening to occur, and families may choose to refuse or opt out of screening on their child's behalf. And finally, newborn screening programs are designed to only screen for those diseases that have specific pre-symptomatic treatment, and this is just one of a number of criteria that diseases must meet in order to be added to newborn screening panels. In the previous slide, I highlighted that newborn screening is a system involving and impacting numerous partners who must all work together to keep the family experience and patient health outcomes at the center. And while we often discuss obvious partners like public health labs and clinicians, researchers, and advocates, this slide reminds us that there are so many more partners at all levels who need to be involved in a newborn screening program for it to be truly successful in meeting its vision and mission. So with that as a foundation, we can move on to focusing on the current role molecular testing plays in newborn screening programs in the US. Here I want to highlight the various reasons why molecular assays might be considered as part of a newborn screening algorithm. The first comes into play when there's no suitable biochemical marker that exists. For example, SCID using TREC analysis and SMA examining the absence of exon 7 in the SMN1 gene. The second application is to provide to improve the performance of a first-tier biomarker. And the most common example here is the use of a variant panel or sequencing for the CFTR gene, which is needed because of the poor performance of its first-tier biomarker, IRT, in the screening of cystic fibrosis. The third reason is to help clarify phenotype, severity, onset of disease, as is the case in the use of reflexed molecular analysis of Pompe and galactosemia. And finally, programs may choose to add molecular testing to help address access issues in general or to assess known variants in certain populations. Currently, newborn screening programs in the US use a number of molecular applications for the purpose of screening. Starting at the smallest circle in red, this involves looking at targeted variants in a single gene, which does not require variant interpretation. So, as I mentioned before, SCID and SMA are assessed using a first-tier molecular assay, looking for very specific molecular targets. Single gene sequencing analysis is being employed by a number of programs as a reflex test. The New York program piloted and assessed the utility of a multi-gene panel as a reflex test for SCID due to the large genetic heterogeneity of that disease, but ultimately found that it was of limited utility. And finally, two programs in Utah and Texas are working towards the implementation of targeted reflex sequencing using exome and genome backbones, respectively. Taken together, we see that all states in the U.S. are screening for SCID and SMA are currently employing a first-tier molecular assay and are using either genotyping and, in a few cases, gene sequencing reflex assays for cystic fibrosis. There are some programs in the U.S. that are using either Sanger sequencing or next-gen sequencing as a reflex for other diseases on their screening panels, and this is accomplished either in-house or through outsourced contract laboratories. And finally, if we look at the coverage of diseases, around 20 diseases on the recommended uniform screening panel are being examined using some sort of molecular assay by at least one newborn screening program in the U.S. So until recently, the expansion of newborn screening programs to include more and more diseases was largely limited by technological advancements, but now our ability to multiplex through the use of tandem mass spectrometry and the expansion of genomic applications, this removes the barrier of identifying sensitive disease-causing biomarkers in the neonatal period. And so we must now shift our thinking. So if testing technology is no longer the limiting factor then becomes the availability of therapy. So we must ask ourselves, just because we can, should we? And if the answer to that question is yes, we should, then we must consider how we should do so in a way that allows for innovation, respects familial autonomy and privacy, and does not exacerbate existing disparities in healthcare outcomes amongst children. To help us consider where sequencing may fit in our public health system, we can look to the considerable lessons learned thus far in the use of molecular testing within newborn screening programs in the US. I could spend a lot of my time talking about the key considerations for expanding molecular analysis in newborn screening programs, but I've chosen just a few topics, both tangible and intangible, to highlight. The first is that the existing public health infrastructure as it stands in the US is not adequate to add genomic level sequencing. The second is that the cost of sequencing has certainly come down substantially in recent years, but it is still not at a level that will allow us to incorporate the population level program without taking funds away from other public health needs. The third is that assessing the current use of single gene sequencing within newborn screening programs, we do see that there is a very high rate of uncertainty with this type of testing. And when we open up sequencing to a population with no true phenotype other than conservatively set biochemical findings, we detect high rates of VUSs, sometimes around 50% of our variant findings, and variants with reduced penetrance, variants conferring variable or age-dependent expressivity, And while certainly the concept of uncertainty is not novel to medicine or specific to newborn screening or sequencing, the considerations around uncertainty need to be examined differently when it is under a mandated model. And finally, there are some very real issues with public perception and trust in public health in the United States. There remain existing lawsuits against newborn screening programs, questioning the constitutionality of mandated screening itself, the ability of mothers to fully provide informed consent within the first 24 hours after birth, as well as the retention and use of dried blood spots. So as we think about expanding the use of molecular testing in newborn screening, education, communication, and transparency need to be at the forefront. Understanding where we're at, what we've learned, I've identified another four high-level considerations for newborn screening in the US, and these include workforce recruitment and retention, improved bioinformatics, data analytics, and AI capabilities, availability of newborn screening quality control materials and resources, and national collaboration. And I'll touch on these a little in the next couple of slides. So the US is currently experiencing a public health workforce crisis, and newborn screening programs have absolutely been impacted. In the last couple of years, nearly 50% of state and local public health employees have left their organizations, and most notably, younger employees still early in their careers. And many of these positions have remained vacant for years owing to the difficulty in recruiting and hiring qualified staff to perform higher level complexity testing and case management. The CDC, recognizing this issue, has funded the Association of Public Health Laboratories, or APHL, to help alleviate workforce challenges, but it still remains uncertain if the public health workforce will be able to rebound. To ensure that the newborn screening programs have resources that they need, CDC has been mandated by Congress to provide quality assurance materials and support for newborn screening programs. Our program, the Newborn Screening Quality Assurance Program, or NSQAP, is the only comprehensive QA program for dried blood spot testing and offers a series of resources to US and international laboratories that are engaged in newborn screening. We are a proficiency testing provider. We create and distribute quality control materials to newborn screening for newborn screening disorders. We evaluate filter paper, and we have biochemical and molecular research laboratories engaged in different kinds of translational research to help improve methods, help create new methods, and so on to help support our programs across the country. In collaboration with APHL, we also offer hands-on training classes, both in biochemical and molecular testing for our states, and we provide one-on-one consultation to laboratories experiencing different kinds of issues and needs for implementation of new disorders. And we also provide site visits and so on. So we're quite busy. In support of quality assurance materials for molecular testing, CDC has been working with various partners for over 10 years to create both dried blood spot reference materials as well as cryopreserved cell repositories made mostly from blood donated by de-identified patients and family members impacted with different newborn screening disorders. And here on this slide, we have repositories for the conditions described on this slide. As we all know in this room, the sequencing itself is not necessarily the most complicated piece of testing. It's actually a lot of the issues are with the downstream bioinformatics and variant interpretation, where that is needed and needed very quickly. And that can make it difficult to actually implement this technology at scale. In discussions with the newborn screening programs across the country about their various data analytic needs, several identified gaps were communicated, and this includes inadequate numbers of data analysts or bioinformaticists within newborn screening programs, the disparate ability and resources of different newborn screening programs to keep pace with the expanding need for data analytics, and the lack of a national data repository for rare disease, and specifically for newborn screening data to help leverage new knowledge and experiences. So appreciating these concerns that were brought up by the newborn screening program, CDC has embarked on a project known as the EDEN platform, which stands really for Enhancing Data-Driven Disease Detection in Newborns. And this project aims to provide a national data solution to newborn screening programs that will help increase the capacity and the infrastructure for data collection, aggregation, and analysis across different public health and medical systems, as well as provide a national data resource that reduces the burden on state programs while providing data analytic resources for all. This is a very high-level schematic of the EDEN architecture that shows our plans to collect 3 primary data types: biochemical and molecular newborn screening data on infants, and clinical diagnostic phenotype data on infants with actionable screening results. So using standard data transfer mechanisms and messaging protocols, newborn screening programs would be able to send de-identified data to EDEN, which will then provide some near real-time patient-level data processing, analytics, and visualization. And we hope that this will ultimately allow for a bit of a modernized and improved risk assessment, enhanced clinical decision support, and the ability to better contribute to new knowledge discovery in rare disease. For the purpose of today, the molecular module within EDEN is probably of most interest, and this image illustrates that EDEN will ultimately provide a complete end-to-end molecular solution for newborn screening programs who wish to use it. We will provide the bioinformatics pipeline, the metadata management, variant identification. A portion of the molecular module is geared towards variant interpretation, providing data from various sources on identified variants and walking newborn screening program staff through the variant interpretation process. Staff will be able to see whether or not their identified variant has already been detected by another program within the newborn screening national group, and how that program classified that variant. Importantly, EDEN will not remain a siloed data set. We will be both utilizing and contributing information to ClinVar, and we have also contracted with Mastermind Genomenon to help provide literature search functionality and to utilize their ongoing curation efforts. Finally, as we look at the implementation of newborn sequencing, we do need some national level collaboration in 4 areas. The first is that of centralization, particularly around implementation of this type of technology, as well as aggregation of data across newborn screening programs. There have been several conversations thus far on the idea of centralization and collaboration, and one emerging concept is the potential for the creation of a newborn screening center of excellence. The second addresses engagement, specifically rebuilding public trust and considering how to involve families of all lived experiences in these processes while addressing known issues of privacy, ethics, equity. The third is improved integration of existing systems, both within public health and medicine. The implementation of newborn sequencing inherently will require participation of programs that assist families with rare disease, as well as engaging interoperable data systems that allow us to assess our impacts and make improvements when gaps are identified. And finally, we need partnerships that include both public and private entities, and the commitment to a learning public health and healthcare system. To end, I just want to focus on the potential path forward towards newborn sequencing. So when we think about the journey, it is important that we are using similar language and understand the implications of certain terminology. When I think about public health-based newborn screening, we need to be clear that this is referring to a population-based universal public health system. In the US, this program is mandated and uses an opt-out model. To justify the mandate, we rely particularly on a legal doctrine known as parens patriae, which allows the state to be regarded as the legal protector of citizens who are unable to protect themselves, in this case, newborns. So for diseases to be added to the newborn screening panel, they must first meet criteria, most notably an effective and pre-symptomatic treatment. On the other hand, when we talk about newborn genome sequencing, we're talking about projects that are typically being done in a clinic or hospital setting using a consented model. In full genomic sequencing, if full genomic sequencing is actually being done, then the reporting of findings may include both treatable and untreatable diseases and may rely on medical guidelines for reporting of secondary findings. So the question remains, how do these two programs that use decidedly different models and have varying considerations start to come together? Where does newborn sequencing ultimately live? In public health, at the bedside, in clinical care, or somewhere else? And to help answer this question, we must clearly define the joint vision and the end goal for the use of this technology in healthy newborns, and screening for healthy newborns. So as much as I would like to stand up here and say that I have all of the answers, I really, literally don't. And I do have a lot of questions, though. And like many of you, once we start providing clear answers to these questions, this may lead us into the best direction that we should follow. In the interest of time, I won't go into the details of all the considerations that are outlined here. It's important, though, to consider questions in and around treatability, manageability, mandates versus consent, data management and handling of uncertainty, balancing innovation and equity, and acknowledging sometimes that biochemical information may be just as, or if not more, informative in some cases. So as we work towards addressing all of these questions, we can still begin the journey to create the public health newborn screening program capacity to integrate this technology. Today, as I've mentioned, programs are starting to use next-generation sequencing for single gene or targeted genotyping. In addition, we have early adopting programs already exploring and preparing to implement genomic and exomic technologies as reflex testing platforms. And as has been the experience in implementation of other new technologies in newborn screening, these early adopting programs can then serve to provide lessons learned to the community at large, train other programs looking to similarly expand their testing, or perform the testing and analysis for programs wishing to outsource. From our vantage point today, it is still difficult to predict the extent to which whole genome or whole exome sequencing will be adopted, how it will be adopted into the routine workflow of newborn screening programs. In the interim, there is much to be learned and understood over the next few years as pilots and research projects present their findings to interested stakeholders and members of the newborn screening and members of the newborn sequencing communities. We look forward to the results of ongoing work in this area to truly understand the critical performance metrics of these pilot studies, as well as the clinical outcomes of the pilot participants. And we hope that the curation and the analysis of the data will lay an evidence-based foundation on which new ideas and innovation, as well as future decisions, will be built. In closing, the successful future of newborn screening in the US will continue to involve the foundational elements of people, science, policy, and this will become even more important as we expand to include sequencing technologies. As we consider the next step in our evolution, we will continue to incorporate lessons learned to ensure that as we move forward with new innovations, we do no harm to the current newborn screening public health system as a whole. I would like to thank and acknowledge members of the newborn screening community for their dedication. And I would like to thank my CDC colleagues, Amy, Suzanne, and Rachel, for their effort and time and discussion that they put into this talk with me. So thank you again for your attention.
Are you okay taking questions? Mm-hmm. Are you okay taking questions?
Mm-hmm. Sure.
We have time for questions if there are any.
Thanks. Thanks for your presentation. I had just a question on counterbalancing enhanced specificity versus compromising on increased sensitivity by limiting variant callings to pathogenic and likely pathogenic. do you envisage any problems by misdiagnosing patients by not reporting variants of uncertain significance? Because we know that rare diseases are rapidly expanding, and variants can be reclassified to pathogenic or likely pathogenic in the future. And I understand that the healthcare system in the US can be pretty litigious. So are there any potential risks by not reporting on variants of uncertain significance?
That's a very good question. Are you talking about what we're doing now, or presumably what would be done in terms of newborn sequencing as a whole?
Newborn sequencing as a whole, yeah.
So the issue about variants of uncertain significance is a big one, and it's actually one of the big driving forces for why we created Eden, because we recognize that as we're looking at the entire population, if we are making inferences on what we already know, it's not based on all of the different ethnic groups. And so being able to have a place where we have these VUSs so that we can ask others, like, is there a way to reevaluate these things, is a very critical part of the process. So I do acknowledge that I don't have an easy answer for you for that, but we are, again, trying to build Eden for the people who will take over from us as we interrogate and reinterrogate this information, so that we can build a very valuable knowledge base of those VUSs and help understand what they actually mean. So not a clear response to you right this second. I think that it's important to be able to record it. The states will have to decide how they represent this, but we are building a system in which we recognize the importance of that, and in 10 years, 15 years after I've retired, the person who takes on over me after me will have the basis of that information. That's a great question.
Okay. May Baker from Wisconsin Newborn Screening Laboratory. This question is not for me, but I would like to make some comments based on the state practice. So your question about how about the things change, I kind of want to remind everybody, and newborn screening is a risk assessment. So whatever we do, the recommendation is to do the confirmatory test. So we base on the confirmatory test, newborn screening program's job basically done. We hand it to the clinical care. So that's because you have to think about the public health laboratory, certain point will become clinical care. We are not chase VUS all the time. I can give you a typical example. For example, Pompeii, right? We use an enzyme test, then we also do the gene sequencing. The reason we have this the tier is for Pompeii, they have a better gene typing, phenotypic coordination than other conditions. So the variance analysis allowed us to have a sense is infantile or late onset. Also, CRIM positive or negative, we strongly feel that will be adding on the clinical utility. So I think it's very interesting, the enzyme cutoff is very, very important in terms of you get a disease causal variance. I think we are very fortunately in our program, since we incorporate that, every single enzyme flagged, we're able to find a true disease causal variance. And we haven't encountered situation VUS yet. But even we have a VUS, we base on the testing really is the enzyme activities. Confirmatory tests verify further, that's we rely on this function analysis to give us more, at least we call it short-term follow-up at that time, and we feel public health can have some closure. Thank you.